Bonjour.
Thank you very much. Good morning to all of you. I also have slides in English. I'm sorry about it. Potential conflicts of interest. Well, my relationship with the pharmaceutical industry, I'm sure you're familiar with it. Now, what about pyocyanic infections, especially in patients who need extended mechanical ventilation? As you know, this is unfortunately a germ that is quite frequent. This is an observational study performed at European level with major participation of French teams, and both for hospital-acquired pneumonia and ventilator-associated pneumonia, in both cases, we get 16 to 17% of cases. So this is quite a problem, and it's all the more a problem that mortality remains high, 38% in this particular study. So the outline of my presentation is as follows. 3 major points. First of all, how to select initial therapy. Can we improve the modalities of this antibiotic treatment once we have identified the infection agent? And the major issue, probably, how to de-escalate. And in particular, is it possible in such a situation with Pseudomonas aeruginosa infection, is it possible to get back to a single drug therapy? So, selection of initial therapy. 3 rules here to be complied with. When there are risk factors, and here I want to be quite clear, when there are risk factors of this type of agents, pathogens, well, then we do need to use 2-drug therapy. We have solid data, 183 episodes of bronchopulmonary disease in this Spanish trial due to Pseudomonas aeruginosa, and this is the major conclusion of the study. If we look at the proportion of patients who will receive an initial appropriate treatment, when we use a combination of 2 antibiotics, the proportion is 90%. And when we use only 1 beta-lactamine, for example, even though it has a very broad spectrum, well, the rate goes down to under 60%, 57 more precisely, especially if P is 0.09, this will have a strong impact on mortality. So now the issue here is to know whether we want to have a combined therapy, if we want to use aminoglycosin or immunofurazole. Well, the answer will depend on your own ecological situation. You will have to obtain from your own laboratory for the strains that you were able to observe in your unit. You should not look at the strains in other ICUs, in other units in the hospital. You really have to go down to the level of your own unit to be able to answer this question. But at national level, we do have quite a number of arguments in favor of aminoglycosil rather than immunoculozole. And you will see that in France in particular, for AGs, especially for Pseudomonas aeruginosa, the average resistance rate is 10 to less than 25%, and for FQs, we have a much higher rate of above 25%. So, on the basis of this, then you can choose an AG, for example, in combination with beta-lactamine. Well, except for special circumstances, this seems to be the best solution. Second rule. in order to choose the appropriate beta-lactamine, you should never reuse the one that might have been prescribed in the 2 weeks prior to the event in the same patient. I'm mentioning here some work by Trouillet et al., but there are other works as well. 135 episodes of P. aeruginosa VAPs, and Jean-Louis looked at the proportion of strains that would resist to imipenem, ceftazidime, and ciprofloxacin on the basis of whether such elements had been prescribed to the patient in the past. If the patient had already received such antibiotics, for imipenem, it was about half of the strains that were resistant to imipenem, compared to a basic rate of 16.7%. This is common sense, actually. But before you choose for this nosocomial infection which beta-lactamine you want to use, well, please do look at the beta-lactamine that have already been prescribed to that patient. Then you also have to look at the microbiological data of the patient. These infections come rather late on patients where we've already performed microbiological sampling. So if we are lucky enough to have cultures, for example, recent cultures of the respiratory data of the patient, then we can properly choose the appropriate beta-lactamine, provided, of course, we have good mapping of the colonization of the respiratory stem. Then it has to be recent, over the last 3 days, and then you are probably in a position to say which strain is responsible for the infection. The second part of my presentation is the optimization of the treatment, of the antibiotic treatment in patients with this type of bacteria infection. So not only the selection of the anti-infectious drug is important, but also the dosage and the route of administration. And this is the major issue in the pharmacokinetics of this infectious agent, and also the pharmacodynamic aspect. Usually we make a distinction between concentration-dependent antibiotics, that is, those whose efficacy will depend on the concentration between the peak concentration and the AUC and the MIC. This is the case of amino acids and hemiquinolones. And as was said earlier, the way the drug is going to be used, for example, amikacin, will have an impact on the efficacy. You know, it's not simple. This is a work that you've already seen presented in this Congress several times. Two major messages. One, even if you use very strong doses of 25 milligrams per kilo, you will still be below the concentrations that you wish to obtain, 8 to 10 times the MIC of the pathogen agent. And two, if we obtain this target, this pharmacokinetic target, then we probably do improve the patient's prognosis. This is shown in this study. This is not a randomized trial, but still it does show that if we are very careful about the pharmacokinetics and pharmacodynamics of all this, we can have a strong efficacy in the treatment. Now, what about penicillin and bergapenem? Well, here again, the most important parameter is time above MIC of the pathogen agent. And for our type of infections here, nosocomial bronchopneumonia with mechanical ventilation, we have to cover the whole period of time, at least 80%. Now we can, of course, improve this time above MIC depending on the administration route. For example, if we have a low dose of beta-lactamine, if it is perfused in a very short period of time, for example, within an hour, then you will get this concentration curve in the blood with a very quick peak and a time above MIC, which is quite low. Now, it's quite possible to improve this time over MIC with the same dosage, but by extending the length of perfusion of the antibiotic. You can see the red curve here, same dosage over a period of 4 hours instead of 1 hour. So potentially, these administration modalities may have some disadvantages. First, the concentration peak is not reached, and therefore this might have a deleterious effect on the penetration of the antibiotic on the infected site. And secondly, we delay the time at which the antibiotic will reach a concentration that is above MIC. So if you use these administration modalities, you have to couple them with a loading dose so that you have an immediate peak and therefore a better concentration of the antibiotic on the infected site, and then reach the MIC of the antibiotic as quickly as possible, both in the blood compartment and on the infected site. So you know that antibiotic penetration in the lung is a very complex issue. On the basis of methodological studies, well, we don't have much data actually because it's very difficult to define this at the level of the lung. Usually the data we have were obtained from alveolar washing with specific techniques to measure antibiotic concentration on the basis of urea. And these measurements are often obtained from healthy patients or patients which do not suffer from any serious infection. And this was done on our type of patients here. And for meropenem, if we can obtain high concentrations with improved pharmacokinetics, for example, if we use continuous perfusion of meropenem, then we are in a position to considerably improve the success rate from 40% with short perfusions to 85% when we use continuous perfusion with loading dose. The pharmacokinetics of anti-infection agent is a complex topic. You know that we have 3 clinical situations. In green, to the right of the slide, you have a proportion of patients, and it's a major proportion of those patients with delayed infection, kidney or liver disturbance. And so there is a decreased clearance and the possibility to obtain very high concentration, but at the price of an increased toxicity, and in particular neurotoxicity that is improved, or at the price of an impact on the digestive flora. So this is a major concern. We need to reach the desired concentration without reaching potentially toxic concentrations. In blue, the group of patients with a normal renal function and liver function, and in this particular case, the pharmacokinetics can be respected, and we can predict and we can know in advance which dose we ought to use. And in red, those are patients who, because of the infection, because of the seriousness of their condition, have a strong clearance of antibiotics and volumes of distribution that are multiplied by 3, 4, 5, or 6, sometimes more, and here high likelihood of getting very low concentrations, far below our targets. And as you know, and this is our problem in ICU, it's very difficult to distinguish between patients, to know whether they are green, blue, or red, according to this slide. We know that those patients in the red group are a major part in trauma-affected patients, and very often they have a renal function that is above normal. So it's very difficult to identify those patients. And we know, as Fabio Taccon demonstrated that in a great number of those patients, with the antibiotics we have, it's very difficult to reach the targets that we wish to reach. For example, for piperacillin tazobactam, only 44% of patients will present acceptable pharmacokinetics for that. Plus the issue of intrapulmonary penetration of antibiotics. And you see that for both beta-lactamine, roughly we do not get more than 50% or sometimes even less than 50% of serum concentration. And this is something that we also have to take into consideration, the issue of antibiotic penetration in the lung. In summary, it is certainly quite possible to improve pharmacokinetics and pharmacodynamics of our antibiotic treatment, but we have to be careful because today this is a game that can potentially be dangerous, because if we want to really be extremely effective, we run the risk of finding ourselves in this type of situation that is constantly below the MIC of the germ. So obviously, we can certainly improve the administration modalities of antibiotics. We have to be very careful about pharmacokinetics of anti-infection agent. Of course, the best solution is to titrate them. We have to be careful also about MIC. Here the message is quite clear. For Pseudomonas aeruginosa infections, we need to have the MICs of the various antibiotics that we want to use on the specific strain that we are faced with from the local laboratory. And now the major challenge of the treatment is to be in a position to fully adjust the dosage and the administration modality on the basis of pharmacokinetic and pharmacodynamic parameters, so that we can have the appropriate concentration of antibiotics on a daily basis before the injection of the next dose, so that we are sure we get the appropriate concentration of antibiotics. And also we need to adjust on the basis of the pharmacokinetics of the antibiotic itself. And this is the issue of therapeutic drug monitoring. But I'm convinced that on the basis of a number of randomized trials, that this is the future, the solution of the future. But of course there is a question mark about the future. Do we mean within 1 year or within 5 years? I don't know. My gray hair allows me to place 2 question marks on the speed at which we'll be able to use TDM. Now, switching to monotherapy after 3 to 5 days, personally I'm convinced, and I'm going to try and convince you as well, that we can switch to monotherapy after 3 days in the great majority of cases. Of course, we need to have the appropriate treatment right from the start, the initial treatment, and then the clinical course has to turn out to be favorable as well, and we'll set aside a number of strains that are particularly resistant to antibiotics, because of course there might be some of them, but in the great majority of cases we can certainly discontinue a combined therapy after 3 daily doses. And I believe that for this we have very solid data. I'm no longer referring to a mechanical ventilation-associated bronchopulmonary disease. We know that there are a lot of details about these infections, but for other types of infections, for example, these Pseudomonas aeruginosa infections, the diagnosis is clear. This is a Spanish study, Carlos Peña, about 261 infections, 593 infections, And Karen Peña compared in the framework of this prospective study, which is really a prospective study, prospective, not only retrospective, on the basis of retrospective data, which were collected more or less prospectively, but here, if we look at mortality, gross mortality and adjusted mortality, well, this mortality was compared in 5 groups of patients, 261 patients without an adequate initial therapy, which means that in Spain and probably also in France, in a great number of cases, initially, we don't find the appropriate treatment. We missed the target. 66 patients had received combination therapy, 2 active drugs on the Pseudomonas aeruginosa strain, 266 empirical single drug therapy, 71 patients with a definitive combination therapy, 2 active antibiotics, and 339 patients where de-escalation had been performed. It was shown here and confirmed that if you don't give an active treatment on the Pseudomonas aeruginosa strain, then you will have an increased mortality rate. So for the empirical treatment, if you give, whether you give 1 or 2 antibiotics, there is no obvious benefit either. Of course, we can discuss this, but what is interesting here in combining 2 antibiotics in the first place is to make sure that at least one of them is going to work and is going to be efficient on the strain. But the benefit is not obvious. If we now look at the final treatment, the overall treatment over the whole period of time of the treatment, as you can see here in red, whether you give 2 antibiotics, and this was here the reference, or if you only give 1 single drug, well, you will see that there is no clinical benefit. And this confirms a number of other papers. So therefore, it means that we can probably de-escalate from D3 to D5 as a maximum on the basis of the various criteria, of course. I will stop here because I want to leave some time for discussion. Thank you very much.